Only mode.
Good afternoon, everyone. I'm Lorna Lucas, Senior Manager of Provider Education for the Association of Community Cancer Centers. I'm eager to introduce Ms. Jennifer Diehl, our expert presenter for the 5th e-course in the series hosted by the Institute for Clinical Immuno-Oncology, or better known as ICLIO, who will discuss managing potential adverse side effects associated with IO agents. As you may know, the ICLIO initiative focuses on preparing the multidisciplinary team for the challenges and opportunities presented by IO and includes other vital resources such as newsletters, papers, the Scholars Program, and a national conference scheduled for this October 2nd in Philadelphia, where Mrs. Diehl will also join us as a faculty presenter. I hope you'll visit www.accc-iclio.org to browse all of our offerings. Now for today's course, I'm pleased to introduce Ms. Jennifer Diehl, primary nurse for the Cutaneous Medical Oncology Clinic at the Moffitt Cancer Center in Tampa, Florida, where she's responsible for clinical management, including the coordination of patient care, the phone triage, and management of patient side effects. Additionally, Ms. Diehl is integral in the counseling of patients and their families from the point of diagnosis through the treatment phases. She has extensive experience working with immunotherapy and targeted therapy in both investigational and standard of care settings, where she currently serves as primary nurse at Dr. Jeffrey Weber. Ms. Diehl's previous roles include work as a clinical research unit infusion nurse and pediatric hematology oncology nurse at the St. Joseph Cancer Institute and Children's Hospital. She earned her Bachelor of Science in Nursing from the University of South Florida and also holds certifications as a pediatric oncology nurse and an oncology certified nurse. And for a few housekeeping notes I just wanted to mention, please feel free to submit any questions you have for our presenter by typing your questions in the box on your dashboard. We also have Dr. Jake Ginto, who's Senior Consultant at the McGivney Global Advisors, joining us today to pose questions that you may have to Ms. Diehl at the end of the presentation. And also, the webinar and slides will be archived and available on the ICLIO website by the end of the week. Again, that's accc-iclio.org. And now I'll send it over to Jennifer to kick off the webinar.
All right, thank you, Lorna, so much. I am honored to be a part of this webinar series and a part of ICLIO. We've been working with immunotherapies for years, and they are definitely a different animal to handle than we were used to before. So we definitely have some things to talk about. So yes, we're going to be talking about managing adverse effects associated with immuno-oncologic agents. The objectives of this webinar will be, by the end of this course, participants will be able to understand adverse events and toxicities related to immunotherapy checkpoint inhibitors, understand how immune-related adverse events, irAEs, present in patients taking checkpoint inhibitors, and understand ways of managing irAEs as it applies to real-world practice. Now, the difference between the mechanism of action in chemotherapy and immunotherapy is that the cytotoxic agents, chemotherapy, directly kill or prevent cells from dividing. They affect the rapidly dividing cells. So in addition to going after the tumor cells, they're also going to go after the oral mucosa, the blood cells, and this leads to things such as decreased blood counts, resulting in fatigue. Patients are at risk for infection. With immunotherapy, this stimulates the innate immune response against the tumor, resulting in irAEs, causing inflammation. So depending on what part of the body becomes inflamed, this is the side effects that we see. So novel immunotherapy agents are becoming the new standard of care in oncology, and clinicians will need to understand and learn how to manage irAEs related to these agents. Next slide. The FDA has approved immunotherapy checkpoint inhibitors, including Ipilumumab, or Yervoy, Nivolumab, or Opdivo, and Pembrolizumab, or Keytruda. Now, Ipilumumab, which is approved in 2011, is a human monoclonal antibody that binds to the cytotoxic T lymphocyte-associated antigen 4, CTLA-4, on T cells. Ipilumumab is indicated for the treatment of unresectable or metastatic melanoma. Nivolumab or Pembrolizumab are human monoclonal antibodies directed against the programmed Death1 PD-1 receptor on the T cells. Nivolumab has indications for use in patients with unresectable or metastatic melanoma and in patients with non-small cell lung cancer. Pembrolizumab is indicated for the treatment of patients with unresectable or metastatic melanoma. And both of those were approved in 2014. Now, this is a diagram demonstrating the mechanism of action with checkpoint inhibitors. So tumors express checkpoint proteins on their cell surface to escape detection from the immune system in the presence of anti-CTLA-4 on the left and anti-PD-1 on the right. The inhibition signals the T-cell activation are blocked, and this, in turn, enhances T-cell activation and subsequently strengthens anti-tumor immunity. Next slide. Now we're going to review some toxicity data from selected clinical trials utilizing these drugs. So this is data from an Ipilumumab trial. This is only melanoma. And this is info from a phase 2 randomized double-blind dose-ranging study. Patients with pretreated advanced melanoma, they received Ipilumumab monotherapy every 3 weeks for 4 cycles, followed by maintenance therapy every 3 months. Now, with Ipilumumab, it was found that toxicities are dose-related. There was 3 dose ranges, the 0.3 milligram per kilogram, the 3 milligram per kilogram, and the 10 milligram per kilogram. There were no grade 3 to 4 adverse events with the 0.3 milligram, but there was 7% with the 3 milligram per kilogram, and actually 25.4% of patients had grade 3 to 4 adverse events in the 10 milligram per kilogram. The most common grade 3 to 4 adverse events, so again, there was none experienced in the 0.3 milligram. The 3 milligram per kilogram was GI at 2.8%, skin 1.4, and endocrine 2.8. In the 10 milligram per kilogram, GI was 15.5%, skin was 4.2%, and endocrine was actually lower at 1.4%. Now, Ipilumumab's indicated dose is 3 milligrams per kilogram that we use now. In this trial, adverse events leading to discontinuation is drug-related, any grade. The low dose is 0.3 milligram per kilogram, 2.8%, and some of these reasons included asthenia or weakness and bone pain. In the 3 milligram per kilogram, 7% patients discontinued, and this was including Enteritis grade 2, hypopituitarism, hydrocephalus, confusion, and respiratory tract infection, and also grade 3 diarrhea. And in the 10 milligram per kilogram, the most frequent was diarrhea grade 3, and that was 15.5% discontinued. Next slide. So this is adverse events from a melanoma Nivolumab trial. This is patients with advanced melanoma who have received greater than 1, but not more than 5 prior systemic cancer therapies, enrolled between 2008 and 2012, receiving Nivolumab every 2 weeks for up to 96 weeks. There were 107 participants in the trial. Now, with this, toxicities did not appear to be dose-related. There was 3 doses, 0.3 milligram per kilogram, 3 milligram per kilogram, and 10 milligram per kilogram. 16.7% of patients experienced grade 3 to 4 toxicities. In the 3 milligram per kilogram, 35.3% experienced grade 3 to 4 toxicities. And in the 10 milligram per kilogram was actually lower. 25% of patients experienced grade 3 to 4. The most common grade 3 to 4 adverse event was fatigue, and diarrhea and abdominal pain were all the same at 1.9%. And lymphopenia, which is low levels of lymphocytes, is 2.8%. Now, discontinuation rate can vary. In a randomized, this is another trial, a randomized open-label trial with 268 patients with unresectable or metastatic melanoma receiving Nivolumab 3 milligrams per kilogram every 2 weeks. Discontinuation from adverse events was about 9%. Next slide, please. So this is a clinical trial for non-small cell lung cancer with Nivolumab. This is a phase 1 dose-escalating cohort expansion trial for patients with advanced non-small cell lung cancer, squamous and non-squamous, heavily pretreated, to receive Nivolumab every 2 weeks in 8-week cycles for up to 96 weeks. Now again, toxicities do not appear to be dose-related. Now these are different doses than in the melanoma trial. They started at 1 milligram per kilogram, 3 milligram per kilogram, and 10 milligram per kilogram. The percent any adverse events, grade 3 to 4 by dose, with the 1 milligram was 15.2%, with the 3 milligram was 13.5%, And then with the 10 milligram per kilogram, that's about the same at 13.6%. Now, patients were counted only once for any adverse event data for only those events that were reported in at least 3% of the patient population was presented. Nivolumab's indicated dose for non-small cell lung cancer is 3 milligram per kilogram. The most common grade 3 to 4 adverse event, fatigue 3.1%, decreased CD4 lymphocytes 2.3%, pneumonitis 2.3%. For those patients experiencing treatment-related adverse events, any grade, the most common were fatigue at 24%, decreased appetite at 12%, and diarrhea with 10%. Now, 3 treatment-related deaths were associated with pneumonitis, but there was no relationship between the pneumonitis and the dose level and the duration of treatment found. Higher grade select adverse events with immune etiologies were manageable in most cases through drug discontinuation, immunosuppressive agents, and/or hormone replacement. Next slide. This is adverse events from a Pembrolizumab trial for melanoma. This is a phase 1 trial, patients with advanced melanoma who have progressed after prior Ipilumumab, treated with Pembro every 3 weeks. Again, with the prior PD-1 antibodies, toxicities do not appear to be dose-related. The percent of adverse events grade 3 to 4 by dose in the 2 milligram per kilogram were 15%, and at 10 milligram per kilogram was actually lower at 8%. Pembrolizumab's indicated dose for melanoma is 2 milligram per kilogram. Grade 3 fatigue reported in 5 patients in the 2 milligram per kilogram pembrolizumab group was the only grade 3 to 4 event reported in more than 1 patient. Now, with adverse events leading to discontinuation, drug-related any grade, 2 milligram per kilogram, actually 7% of the patients had a DC treatment, and in the 10 milligram per kilogram, 11% of the patients DC treatment. The most common related adverse events in the 2 milligram per kilogram, fatigue was 32.6%, pruritus was 25.8%, and rash was 18%. In the 10 milligram per kilogram, fatigue was 36.9%, pruritus was 19%, rash was 17.9%. Next slide, please. So here's some bullet points. Most irAEs occur within the first 3 months of treatment, i.e. induction with an immunotherapy, but some occur after the final dose. So it's important these patients know that these can happen weeks to even months after the final dose. Toxicities may be dose-dependent with ipilimumab, but not with the PD-1 antibodies. irAEs can depend upon tumor groups, can differ depending on tumor groups. The severity of the toxicity, grade 1 to 4, dictates how to manage the irAE. In general, treatment is either withheld or discontinued in patients experiencing moderate to severe irAEs, grade 2 through 4. Thyroid function, blood count, liver function, and metabolic panels are tested during treatment of checkpoint inhibitors. We always check them at baseline and then prior to every dose. And it's very important that you wait for your labs before sending these patients on to treatment, as some of the elevations can be asymptomatic. The following slides will focus on the presentation and management of irAEs as they apply to ipilimumab, nivolumab, and pembrolizumab. Okay, so we'll start with dermatologic irAEs. They're the most frequent reported adverse event. They're typically mild to moderate in severity. Less than 3% are grade 3 or higher. Types of irAEs include maculopapular rash and pruritus. Now, these can be together or separate. Vitiligo, alopecia. Management, grade 1 to 2. Symptomatic therapy such as moisturizers, ointments, low-dose topical corticosteroids, and antihistamine. Things we commonly use are Eucerin cream, Aveeno cream, Benadryl orally or Benadryl cream. Atarax works really well. That's kind of our go-to lately for the itching. And 1% hydrocortisone for hot spots. Grade 3 to 4, evaluate by a dermatologist. Administration of systemic corticosteroids, prednisone or equivalent, and drug interruption. We also, for the lower grades, we have them also take like lukewarm baths and showers and avoid any sort of new lotions except the ones that we tell them to use, perfumes and detergents. And one thing I just want to say is, especially with Yervoy, be on the lookout for possibly severe skin reactions, Stevens-Johnson syndrome, toxic epidermal necrolysis or rash complicated by full thickness dermal ulceration or necrotic bullous or hemorrhagic manifestations. Could happen with Yervoy. Right, next slide, please. Enterocolitis. Dysregulation of the GI mucosal immunity can result in diarrhea, colitis, abdominal pain, or blood mucus in the stool without fever. First thing you're going to do is rule out infectious etiologies, stool culture, C. diff, and this is more prominent with Yervoy than the PD-1 antibodies, Nivo and Pembro. Grade 1 to 2, you're going to treat symptomatically. We use Imodium first, and then if that doesn't clear up right away, we'll switch to Lomotil, but I'll go over that more in the case presentations. Grade 3 to 4, discontinue treatment. Rule out bowel perforation. If it is present, you do not administer steroids. Once it's ruled out, you can treat patient with high-dose intravenous methylprednisolone. Other steroids can be used, such as dexamethasone or prednisone. And with no improvement, consider single-dose infliximab, and that is very effective. It's usually a one-time dose, 5 milligrams per kilogram, and then we follow that with about a 30-day steroid taper, prednisone taper. It's very important to do a slow taper after that, because if you taper down too quickly, usually the symptoms will come back, and then you need to go back up on the taper. Next slide, please. Endocrinopathies. Endocrinopathy irAEs include inflammation of the pituitary, thyroid, or adrenal glands and occur in less than 5% of patients, with less than 3% being grade 3 or higher. They can present very vaguely. You kind of just need to listen to the patient and sort it out. They can present with headaches, and these headaches can be very severe that usually don't respond to Tylenol or Advil. Fatigue is the most common, and these people are wiped out. They can't get out of bed. Visual field defects, decreased libido, hypotension, mental status changes, abdominal pain, unusual bowel habits, abnormal thyroid tests. Workup is going to include, especially with the MRI, with the headaches, the severe headache, MRI of the brain to rule out brain mets or leptomeningeal disease. And you can also, sometimes see the inflamed pituitary glands right on the MRI. Also, ACTH, cortisol, T4-free, TSH, and testosterone for the fatigue. Management, grade 1 to 2, without adrenal crisis, may resolve spontaneously, monitor closely with potential endocrinological consultation, short-term high-dose corticosteroids if needed, with relevant hormone replacement. And sometimes this hormone replacement can be lifelong. Hypophysitis, which is basically inflammation of the pituitary gland that inhibits its function, high-dose corticosteroid supplementation of effective hormones, and adrenal crisis, which is bottomed out cortisol. Treat as medical emergency, give IV glucocorticosteroids and IV saline with dextrose. Hepatotoxicities. Inflammatory hepatitis has been reported in patients taking CTLA-4 and PD-1 inhibitors. In patients taking IPI, less than 2% present with hepatotoxicity, about 1% are grade 3 to 4. Liver tests should be performed to determine AST and ALT levels, and most episodes are asymptomatic. So again, very, very important to see those blood values before you get the patients treated. Management. You're going to hold for a grade 2, AST or ALT levels greater than 2.5 times, but less than or equal to 5 times the upper limit of normal. Total bili greater than 1.5 times, but less than or equal to 3 times the upper limit of normal. You're going to DC treatment for grade 3 or greater, AST or ALT greater than 5 times the upper limit of normal, bilirubin greater than 3 times the upper limit of normal. Provide high-dose IV corticosteroid therapy, and if refractory to corticosteroid treatment, mycophenolate is recommended, and I've never used that, but apparently it is very effective. Pneumonitis. This occurs more frequently with the PD-1 antibodies, Nivo and Pembro, than with Yervoy, but it can happen with both. It presents usually as a cough, chest pain, shortness of breath, dyspnea on exertion. Patients should be checked either a chest x-ray or a CAT scan. Management, grade 1, may present without symptoms but show up on scans. And for moderate to severe symptoms with radiographic findings, pulmonary consultation is suggested, as well as bronchoscopy to evaluate for infectious etiology. Severe cases may warrant use of IV methylprednisolone and the possible consideration of other immunosuppressant agents such as infliximab, mycophenolate, or cyclophosphamide. We usually, all of our patients receiving PD-1 antibodies, we check O2 stats before and after exercise to routinely check them. Other irAEs associated with checkpoint inhibitors, ocular, eye inflammation from episcleritis, conjunctivitis, uveitis, ophthalmopathy associated with Graves' disease, symptoms, photophobia, pain, dryness, blurred vision. Recommend to consult with an ophthalmologist, not an optometrist, an ophthalmologist, if experienced any visual disturbances. Topical corticosteroids may be useful for grade 3 to 4. Eye drops and oral corticosteroids may be used. Neurologic irAEs, Guillain-Barré syndrome, inflammatory myopathy, posterior reversible encephalopathy syndrome, aseptic meningitis, enteric neuropathy, transverse myelitis, or a few of the neurotoxicities that can happen. Symptoms included muscle weakness, sensory neuropathies, or motor neuropathies. Now this can be bilateral or unilateral. Serious events are treated with steroids, consultation with a neurologist. So other irAEs in patients taking checkpoint inhibitors can also include events related to kidneys and pancreas, and actually both of those are going to show up in the case presentations, and also hematologic ones. Now, I will tell you a couple things really quick. Is all three of these drugs have great guides that go through, and they'll show you exactly what is a grade 1, 2, 3, 4, and then specific guides to management. So those guides are really handy to help have in your office and have the staff familiar with them. Key takeaways: adverse events differ in patients taking cytotoxic agents versus patients taking immunotherapy checkpoint inhibitors. This is a result of the immunotherapy's unique mechanism of action. Clinicians need to understand how irAEs present as well as how to manage them. 3 checkpoint inhibitors are approved by the FDA: Ipilumumab, Nivolumab, and Pembrolizumab. irAEs occurred including but not limited to dermatologic toxicities, Enterocolitis, gastrointestinal irAEs, Endocrinopathies, Hepatotoxicities, and Pneumonitis. Severity of the toxicity, grade 1 through 4, dictates how to manage the irAE. In general, treatment is either withheld or discontinued in patients experiencing moderate or severe irAEs, grade 2 through 4. Less severe irAEs can be treated symptomatically, with more severe irAEs often requiring steroid use. Consultation with a specialist is often recommended. You definitely have an endocrinologist at your disposal, dermatologist, neurologist, and sometimes even a hematologist. Okay, we're going to go through a few case studies right now. We'll start with the first one. This is a 67-year-old male he's going to experience colitis followed by pancreatitis and pneumonitis. So it's a 67-year-old male with stage 4 melanoma, lung, adrenal, and liver, on a clinical trial utilizing sequential ipilimumab followed by PD-1 antibody, randomized to receive ipilimumab first. So he presented at clinic in week 7, previously tolerating treatment well, presents for dose 3 of ipi, continues to feel well. He's active, walking, he plays golf. No complaints of diarrhea, cramping, abdominal pain, or blood per rectum. Reminded to call for adverse effects. We go over it every time: fatigue, rash, itching, diarrhea, shortness of breath, cough, and return to clinic in 3 weeks or call for issues. So he calls, week 8 phone call, 5 days post-treatment. Patient calls stating that he has had diarrhea for 4 days. He's unsure of how many episodes per day, and he has been taking Imodium sporadically. Now, I will tell you this was actually over Thanksgiving, so he kind of attributed it to eating heavy, rich foods. So we contacted the MD, and the instructions were, and this is our usual, what we'll use, Imodium, 2 tabs PO with the first diarrhea of the day, and then 1 tab with each additional diarrhea, up to 8 tabs a day. Lomotil, 1 tab PO QID on days with diarrhea. So if he didn't have diarrhea, he would not take the Lomotil, and then he wouldn't take the Imodium because that was actually with each diarrhea. And budesonide, 3 3-milligram tabs, so 9 milligram dose, PO QAM for 10 days. And he takes all 10 days, no matter what, even if the diarrhea stops. And then call us if no improvement. Next slide, please. So we called a few days later. He continues with diarrhea. His stools were firmer. They're not as watery as they were last week. Had 3 stools yesterday. He continues with Imodium, Lomotil, and budesonide, but probably up to 7 stools the day before. And we also received a lab report from the PCP that his stool was positive for occult blood. So we contacted the MD. Instructions are to continue Imodium, Lomotil, and budesonide, and add a prednisone taper, starting at 8 milligrams a day, decreasing by 10 milligrams every 3 days for a 24-day taper. He's to call if no improvement. So he presents back to clinic, week 10 clinic visit on schedule. He would be due for dose 4 of Ipilumumab. 15 days into steroid taper. Diarrhea had completely resolved within days after starting steroids. Patient feeling well, energy 80 to 90%, played golf twice a week. The plan is to continue steroid taper. We'll skip dose 4 Ipilumumab, get rescanned, and plan to return to clinic in 3 weeks. Week 13 clinic visit, post-scans, pre-PD-1 antibody, off steroids for 10 days, 1 episode of diarrhea last week controlled with Imodium, scan showed stable disease. The plan was to proceed on trial with PD-1 antibody. Next slide, please. Week 26 clinic visit. He's been tolerating PD-1 antibody without toxicity so far. CT scans show a partial response, grade 1 diarrhea controlled with Imodium, and grade 1 elevated lipase. Plan was to proceed with PD-1 antibody. So over the next 5 months, he had occasional grade 1 to 2 elevated amylase and or lipases. Asymptomatic, no problem. He was treated on schedule. Week 47 clinic visit. He presents to clinic for PD-1 antibody on schedule. Grade 3 amylase, which is 2 to 5 times the upper limit of normal. Grade 4 lipase, which is greater than 5 times the upper limit of normal. Asymptomatic. Plan was to hold PD-1 antibody, Medrol dose pack, return to clinic 2 weeks on schedule after CT scans, and call ASAP for indigestion, abdominal pain or discomfort, nausea and or vomiting, and if it was bad, he was just to proceed right to the ER. He was also to avoid fatty, spicy foods. Week 49 clinic visit, scans show confirmed PR, grade 2 lipase, asymptomatic. Plan was proceed with PD-1 antibody. Week 51 clinic visit, grade 3 lipase, asymptomatic. Plan proceed with PD-1 antibody. Week 64 ER visit, presents to ER with abdominal pain, bloating, and nausea, no vomiting. He had called the MD, and the MD instructed him that if it didn't get better, to just go ahead and go to the ER. The findings in the ER, his lipase was 1,348. CT abdomen shows inflammation surrounding pancreatic head consistent with pancreatitis. The treatment was IV Medrol in-house times 2 days. DC home 2 days after admit on a Medrol dose pack. Amylase at discharge was 69 and lipase at discharge was 300. Next slide. Week 65 clinic visit. He feels much better, grade 1 lipase. The plan was due to admit for acute pancreatitis. Decision was made to discontinue therapy but continue to monitor him on trial but off active treatment. Complete the Medrol dose pack, avoid fatty foods and alcohol intake, return to clinic 2 weeks, and call clinic for any symptoms. Week 67 clinic visit following bland, low-fat diet and decreased alcohol. Back to usual activity. He was golfing 4 times a week. Lipase and amylase were still grade 3. Plan was to check labs at PCP in 2 to 3 weeks. Call ASAP for abdominal symptoms. Week 69, the labs at PCP were actually back to normal. lipase was 54 and amylase was 45. Week 84, scans are stable. Symptoms: new chronic dry cough, no shortness of breath, hemoptysis, increased sputum or dyspnea on exertion. He felt great otherwise. Findings: O2 sat was 99% at rest and after activity. CT scan shows possible pneumonitis. The plan was return to clinic in 6 weeks for an interim CT scan. Call ASAP for worsening pulmonary symptoms or other issues. Week 90, patient feels good with 90% energy, playing golf daily. Cough is the same without change in sputum production. Patient denies shortness of breath, but he does have dyspnea on exertion. Findings: O2 saturation 97% at rest and 90% after activity, so he did desaturate. CT scan shows progression in pneumonitis. PE reveals bronchi bilaterally. Plan: prednisone 30-day course with a decline by 10 milligrams every 3 days until finish. Add Zantac and Protonix due to known reflux with steroid therapy. Return to clinic 2.5 weeks for PE and labs. Week 93, feels much better. Patient is currently at a dose of 40 milligrams in the prednisone taper. Patient has minimal cough but denies shortness of breath, increased sputum, hemoptysis, or dyspnea on exertion. Findings: O2 sat was 96% at rest and 95% after activity. PE exam reveals clear lungs. Plan: continue prednisone taper with a decline by 10 milligrams every 3 days until finish. Continue Zantac and Protonix due to known reflux with steroid therapy, and return to clinic in 4 weeks for restaging scans. So actually, we did see him once after that for week 97. He feels great. His pneumonitis is improved, and he is doing fine. All right, so we'll go to the next case study. This is enteritis and nephritis. So this is a 42-year-old male with a history of stage 3C resected melanoma from the right groin with 10 of 24 positive nodes, received 6 doses of Nivolumab on an adjuvant trial, then had restaging evaluation scans showing no disease. 2 weeks later, just prior to schedule of the 7th dose, he came into clinic complaining of 2 days of anorexia, nausea, 1 episode of vomiting, and 1 episode of diarrhea. The temp was 101.5 degrees Fahrenheit, creatinine was 1.2, and he mentioned that he had dark urine. He was admitted to the hospital, had blood cultures, was started on broad-spectrum antibiotics, and had another diarrhea stool just after admission. C. diff titers were taken, and he was hydrated. KUB upright shows an ileus. CT scan shows no colitis, but some small bowel stranding. The C. diff was positive. The patient was treated for C. diff with vancomycin, but the ileus did not improve, with requirements for narcotics for pain relief. The patient had 7 diarrheal BMs the next day. Steroids were instituted 48 hours after admission, with 125 milligram Solumedrol given twice a day, IV piggyback, then 125 milligram once, IV piggyback. Next slide, please. The patient improved rapidly. The diarrhea disappeared, and he was discharged on 100 milligram prednisone taper orally on the 5th day after admission, eating normally. He was better when seen a week later, and then 2 weeks later he felt well. The steroids finished in 40 days, and he returned to work as a PE instructor and coach 2 weeks after discharge on steroids. 2 weeks after finishing the steroids, he began to have nausea and anorexia. 2 days later, he developed a fever and contacted the on-call physician. He was told to come to be seen at the hospital. He had a fever of 102, creatinine of 1.3, dark urine, and severe nausea. The abdominal exam showed minimal diffuse tenderness without rebound noted. CT scan showed no changes of enteritis or colitis, but stranding around both kidneys. The patient was hydrated and treated with empiric antibiotics. There was no clear diagnosis. The next morning, he still felt poorly with low-grade fevers and creatinine of 1.4, taking nothing by mouth. KUB abdomen upright were unrevealing. 48 hours after admission, creatinine was 2.0 with less than a liter of urine, feeling a bit improved with low-grade fevers. The next day, his creatinine was 2.8, BUN was 12, and continued anorexia, nausea, vomiting, controlled with Zofran. He was started on IV Solumedrol at 125 milligrams BID for 2 days. The next day, the creatinine was 10.4, then 1.9 the day after. He started to take fluids by mouth and was afebrile. He was switched to 120 milligram prednisone, PO tapering over 48 days, and he was discharged home 6 days after admission, tolerating a bland full diet. We have seen him since, and he is actually doing great. So these guys are doing well now.
Excellent. All right. Well, thank you so much, Jennifer, for the presentation. So we do have a few more moments to take some questions that have come in. So I'm going to hand it over to Dr. Jake Ginto, who's going to discuss the questions with Jennifer Diehl.
Thanks, Lorna, and thank you, Jennifer, for a very educational webinar. So we do have a number of questions. The first question has to do with contraindications and autoimmune diseases. So is there a contraindication to using immunotherapy agents such as Nivolumab in patients with autoimmune diseases such as lupus or rheumatoid arthritis?
So basically, in the clinical trials, most patients were excluded that had underlying autoimmune diseases. But I spoke to Dr. Weber just to see kind of where we are at right now, and basically he says history of autoimmune disease itself is not an absolute contraindication. However, active major autoimmune disease requiring therapy, he says, is definitely a no-no.
Okay, thanks. So the next question that we received has to do with non-immune related adverse events associated with immunotherapy. So in your real-world experience, what other types of side effects or adverse events have you observed that are not specifically immune-related when managing patients taking checkpoint inhibitors? For example, administration-related events, injection site reactions, etc.
Sure. We have had a few infusion reactions over the years to actually all of the drugs. We've had during a rash, shortness of breath, back pain develop. What we'll usually do is we'll stop immediately. We administer Zantac 150, Benadryl, and Tylenol, and then we'll watch them for a little while, and if their symptoms resolve, we'll start back at a quarter rate and then a half rate, and we usually will stay there until completion. And then afterwards, these patients will be pre-medicated prior to their treatment, and we usually will start at the lower rate and try and see if they can tolerate it that way. Another one that we've seen, and it's been a number of years, and this is all with Yervoy, but we have had some decreased platelet counts with Yervoy that you really don't see a lot of, but we've had a couple, 3 patients that I can think about that, where we all of a sudden have platelet counts like 1,000, 2,000, 3,000 just out of nowhere. And those patients, we tried IVIG in the beginning, and we really didn't get any response with that. We tried prednisone tapers, but it wouldn't last long. And our hematologist we were working very closely with, and he actually ended up using Promacta with these patients, and we actually ended up having some response with that finally, because that was weighing on us for a while, because we would end up getting these same patients back. But there's only 3 cases of that I can actually remember over the last 7 years.
Okay, thank you, Jennifer. So the next question has to do with combination regimens of taking more than one immunotherapy at the same time. So immunotherapy combination regimens, such as Ipilumumab plus Nivolumab, are in development for the treatment of cancer. Have you treated patients with immune-related adverse events resulting from an immunotherapy combination regimen? And if so, what are your experiences in treating and managing these patients?
Yes, we've had a number of these patients, and they are going to have a higher rate of toxicities, especially the grade 3 to 4 toxicities. And just education is so key with these patients, and timely reporting of any side effects, especially diarrhea seems to be the big one to us, so that we can manage it quickly and effectively, and try to not have to interrupt treatment. There's a few patients that they would get 4 doses of Ipilumumab, and then they would switch to Nivolumab, and a few of them crashed like right after the first dose of Nivolumab. So you're like trying to think, do we attribute this to the Ipilumumab or the Nivolumab? And I think we pretty much determined that we were going to attribute that to the Ipilumumab. But yeah, they can absolutely have increased toxicities, and you just have to really educate these patients that they have to be in contact with you so that you can manage them.
Okay. Now, have you noticed any side effects or interactions with patients getting radiotherapy?
No, not that anything that comes to mind, because we'll usually do that first, and then we'll start our Yervoy afterwards. Another interesting one we're doing now is actually a patient with leptomeningeal disease that we're going to start treating with Yervoy, and that she also gets injections into the spinal fluid of cytotoxic, and we have to, how we're doing that is like we're going to treat, she gets that every week, and then we just have to make sure the Yervoy is separated from that by 48 hours. So this is the first one that we've done, but this is kind of a complicated treatment regimen, so everybody knows exactly what they're doing, but this is what we're trying to do for this patient.
Okay, great, thank you. Another question that came in, have you noted any dose-limiting fatigue or any fatigue during treatment holiday?
You mean after they're completed with treatment?
Yeah, that's how I'm interpreting the question. So.
Well, basically, with fatigue, we're always going to do the workup. We're going to do the ACTH, cortisol, in testosterone, and everything, and we're going to check any abnormalities. And if there are any abnormalities, and that can happen after the end of treatment. And then absolutely, if there's any abnormalities, then we're going to go ahead and, depending on what's abnormal, put them on hydrocortisone or Synthroid. And we do use a lot of that, and we do use our endocrinologist quite frequently. So yes, I'd say definitely after the treatment is done, these can still present themselves.
Okay, and I think we have time for one more question. And this has to do with comorbidities. So in addition to cancer, many patients may exhibit comorbidities. For example, cardiovascular diseases, diabetes, etc. How do you take their comorbidities in consideration when deciding how to manage their immune-related adverse events?
Well, the main one that jumps out right now is diabetes, because we end up having to, get steroids involved so often that it's important to be aware of, what they're on for their diabetes. And then if we end up using steroids for anything, that they're checking their blood glucoses very frequently. And I can remember a patient years ago that they were very, very fatigued, and their hormone levels were abnormal, so we started them on steroids, and they didn't feel any better, didn't feel any better, didn't feel any better. And then it wasn't until we thoroughly went through the meds and everything and realized they were on Januvia that it's like, has anybody checked the blood glucose? And the blood glucose was like 600. And so, then obviously we could, get the patient in and get them fixed. But, definitely just need to be aware of all the medications they're on, and especially with steroids, the different ways that they can affect the other things going on with them.
Great, thank you. I think that's the amount of time we have for questions. I'll give it back to you, Lorna.
Great, thank you. Well, again, thank you so much, Jennifer and Jake, for the engaging presentation. It was wonderful to hear your insight and your experience dealing with these agents. Again, I want to say thank you to our audience for participating today. The webinar and slides will be available shortly on our website. Again, that's accc-iclio.org, accc-iclio.org. And also, all registrants will receive an email with the link. So thank you so much, and have a great rest of your day.